All right, as folks are logging on, I'd like to welcome you to another wonderful Department of Medicine Grand Rounds this Friday. And as a reminder for all of you folks, if you have questions for our speaker, feel free to put them in the Q&A box or in the chat box, and I will monitor it. And if we have time at the end, we'll hopefully get through as many as we can. So thank you all for being here, and it is my pleasure to introduce our speaker today, Dr. Rashmi Sharma. Dr. Sharma completed medical school and internal medicine residency here at the University of Washington, and then went on to complete a GIM fellowship at Johns Hopkins, where she also received her master's in health sciences. And then she later returned back home here to the University of Washington, where she joined the Division of General Internal Medicine in 2015. And she was selected by the American Academy of Hospice and Palliative Care Medicine as one of only 44 hospice and palliative medicine inspirational leaders under 40, and was a recipient of the 2016 Hastings Center Cunniff-Dixon Early Career Physician Award for the quality of her research in palliative care and care of patients at the end of life. And not only is she a clinician, but she also serves as co-chair of the American Academy of Hospice and Palliative Care Medicine's Diversity, Equity, and Inclusion Committee. So she has a lot on her plate. So we're very thankful to have her here to speak with us today. So I'll hand over the virtual podium and let you take it away.
Sounds great. Thank you so much for such a nice introduction. So I have no conflicts to disclose. And in terms of the outline for this presentation, I'm going to start by giving a brief overview of the concept of health equity and some of the drivers of health disparities. Then I'll present some of the demographic data for the limited English proficiency population here in the US. And then I'll briefly review some of the literature on limited English proficiency, disparities in healthcare outcomes. And then finally, I'll turn to literature on the outcomes of patients with serious illness in particular, and end with some thoughts on the path forward as we think about how to address inequities for this population. So when thinking about health equity, I think it's clear to people that over the last few decades, there have been many studies looking at the detection of health differences between different groups. Differences that reflect social, economic, and environmental disadvantage. A lot of that work had focused on the idea of achieving equal outcomes. I'm sure many of you have seen a graphic that looks like this, or some version of this cartoon, kind of highlighting the difference between equality and equity, and showing kind of how we've evolved even within a research lens to thinking about some of these issues. As you can see in the cartoon on the left, the person on the far left is well able to see over the fence with the addition of this one box. So here the idea is that you give all of these people the same thing, that you would have the same outcomes. Clearly for the person in the middle, that one box is not quite enough, although it was helpful. And for that person on the right, the box was not helpful at all. So if we change the way we're thinking about this to really think about equity, here our goal is to do everything that is needed to help all three of these people see over the fence. And in this case, that meant 2 boxes for the person in the middle, and the person on the right actually needed a ramp. So as we think about this field, how can we make sure, recognizing that everybody is not coming from the same starting point, how can we ensure that people have equal opportunity to optimal health? I'm not going to spend much time on this slide. This slide in and of itself could be a whole talk, and actually others have given this talk. But I do want to mention, as we think about some of the drivers of health inequities, there are structural inequities, there are social determinants of health, as you can see in this graphic here on the side, and there are healthcare disparities. And there we're talking about things like clinician behavior and system level factors. And that's really going to be the place that I'm going to focus on today. So in this kind of adapted version of the conceptual framework from Kilborn and colleagues, you can see the multiple levels at which healthcare barriers exist to equitable care. You can see on the left that we have patient and family factors. That includes things like beliefs and preferences that reflects people's race, ethnicity, culture, their familial context, something we think about a lot in palliative care, their education, health literacy, resources. Then you have the clinical encounter, in which a lot of that is really about communication. And as we'll talk about for patients with limited English proficiency, the use of interpreters as well as kind of cultural competence. On the right there, you can see provider factors. So now we're thinking about some of the knowledge and attitudes and implicit bias, an area that I think is really getting a lot more attention in work these days. And then, of course, we have healthcare system factors as we think about how the organization is structured, the culture within the organization. And then again, because this talk is focused on those with limited English proficiency, we also think about system level factors in terms of language assistance and access to language services. Okay, so let me talk a little bit now about who makes up the limited English proficiency population in the US. This is a rapidly growing population. And I want to start with how we can define limited English proficiency, or LEP, and there are a couple of different approaches to this. One that you'll see in a lot of epidemiologic work and kind of studies that are based on demographic data is using the definition from the US Census Bureau. So for folks who are filling out the census form, one of the questions is, how well does this person, the person filling out the form, speak English? And the options here are very well, not well, and not at all. So everything below very well is categorized as limited English proficiency. So that's including then, as you can see, when people say that they speak English well, not well, or not at all. Now, the other approach is to ask people about their preferred language. So here you see the question that's used within UW Medicine. Patients are asked, in what language do you want to talk to your healthcare team about your care? For all people that answer a language other than English, we consider those people to have limited English proficiency. Now, in a 2008 paper by Carliner and colleagues, they looked at these two approaches to identifying limited English proficiency patients in a clinical setting. So that's using the census definition, which you can see here in this red box, right? So that's including people who indicated that their English proficiency was below very well. They also then looked at, and this study focused on those who were Spanish speaking, also asked people about their preferred language for receipt of medical care. You can see there that the options were English only, Spanish only, or both equally. As you can see, this includes all of the people in the red box who preferred Spanish only. It also, though, does include a small number of people who indicated a preference for either English or both language. In other words, both of these approaches managed to capture all of the patients who indicated a preference for speaking in Spanish only. What you'll also notice is on the very far right side here, the group that indicated the ability to speak English well, you have almost everyone in that group who was able to discuss symptoms in English and able to understand doctors' recommendations in English. The takeaway from this was that both approaches will generally capture the patients who have limited English proficiency, although the census definition will capture a larger, slightly larger group. Okay, so as we think about this rapidly growing population, as per the most recent census reports, those with limited English proficiency make up more than 25 million people in the US. In this graphic, as evidenced by the growing size of the boxes, you can see how the number of people who speak a language other than English has increased over the last few decades. So we're working from left to right on this slide. The other thing that you can see in this slide is the shift in which languages are more commonly spoken in the US. So with the current top 5 being Spanish, Chinese, French, Tagalog, and Vietnamese. And in this slide, you can now see the breakdown by English speaking ability. Again, this is using census definitions. So that means that LEP refers to all of those who speak English less than very well. So on this slide, that's the orange, green, and purple bars. As you look towards the bottom here, you'll see that some of the languages that make up the largest groups in the US, based on that last slide that I just showed you, also have the largest number of LEP individuals. In particular, if you look at the very bottom here, you'll see that Vietnamese and Chinese-speaking populations have more than 50% individuals with limited English proficiency. And as you look at some of those other languages there on the bottom, including Spanish, Korean, and Russian being the number 6 and 7 most frequently spoken languages, you again see really high rates of LEP in these populations. And as we think about the geographic distribution of people across the US in this study from Proctor et al., they looked at data for those with Medicare, Medicaid, or dual beneficiaries. The states in dark blue are the states with the highest proportion of LEP individuals. Again, remember, this is a subset because this is just focusing on Medicare, Medicaid, dual beneficiaries. You can see Washington there as one of those dark blue states. And actually, Washington has the 10th largest number of limited English proficiency Medicare, Medicaid beneficiaries in the country. And this gives you a kind of closer look at the demographics for our state. And I should mention that this is again based on census data from 2013 from the American Community Survey. Foreign-born population making up more than 1 million individuals here in the state of Washington, of whom about 44% report limited English proficiency. You can also see there the numbers for the US-born population residing here in Washington state, of whom actually 1% also report limited English proficiency. And in total, that brings us then to above 500,000. In the pie chart here on the right, you can see the breakdown by language for the state of Washington. You'll see that just under 50% are Spanish speakers. And then in terms of kind of the next set of most frequently spoken languages, we have Chinese, Vietnamese, Korean, Russian, Tagalog, and then in this case, the census data grouped the African languages together. So that making up the next kind of largest group as we think about the local population that we're seeing here within the UW-Medicine catchment area. So now I want to turn to talking about some of the research that we have looking at inequities in healthcare outcomes for patients with limited English proficiency. And again, I want to kind of start with the broader population, and then I'll start talking about the subset of people with serious illness. And I wanted to start by highlighting the national CLAS standards. So in 2013, the Office of Minority Health revised these standards. This stands for Culturally and Linguistically Appropriate Services in Health and Healthcare. And the principal standard here is the idea that we need to provide effective, equitable, understandable, and respectful care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. And as we think about the LEP population in particular, some of the additional standards around language assistance are really relevant here. So those include offering language assistance to individuals with LEP at no cost to the individual, and ensuring the competence of individuals providing language assistance, recognizing that the use of untrained individuals and/or minors as interpreters should be avoided. And I'm highlighting this because, as you'll see, when we start looking at the data about use of interpreters, we'll see that this is an area that we are not doing very well on. All right, so in this first study from Carliner and colleagues that looked at readmission rates, they found that patients with LEP were more likely to have 30-day readmissions than those with English proficiency. On a related note, Divy and colleagues found that for patients with LEP who were experiencing adverse events, they were more likely to experience physical harm. That's 49% for LEP versus 29.5% for those with English proficiency. And not surprisingly, they were more likely to have events due to communication errors. In other words, the communication barriers and language barriers experienced by these patients is translating into adverse outcomes. In this study of Asian and Latino immigrants, Kim et al. Found disparities in multiple aspects of health service use for those with LEP. So you can see here in the red boxes are the groups of LEP for both the Latino and Asian immigrants. EP here stands for English proficiency. In this case, that's referring to people who reported speaking English very well and also speaking another language. So in other words, these are bilingual participants, patients, and then EO is English only. So you can see that's a relatively small number for these two groups, but those are people who only speak English and do not speak another language. The main findings here, as you can see, are significant differences when it comes to patients with LEP having greater difficulty understanding the doctor, understanding written information at the doctor's office, and reading instructions on prescription bottles. They also were more likely to have multiple visits in the past 12 months. And now I want to turn to talking about interpreter use. Remember, going back to those CLAS standards I shared, this is a key area in which we need to provide services to achieve equitable care. In this study, Shankar and colleagues looked at data from 2 San Francisco Bay Area hospitals, and I think it's worth mentioning that the 2 hospitals that they included in their sample had inpatient interpreter services for all of the languages that they were looking at, as well as access to audio and video interpretation, right? So in other words, these are places where there's ample access to interpreter services. And yet, what we see here is a striking number of patients who did not have interpreters present, either at admission or since admission with physicians or nurses. So this red box that I've highlighted here, and now I should be clear that patients were asked if they had any kind of an interpreter present, so that they separated out if it was a professional medical interpreter, a family member, a nurse, or physician. So this red box is people who had no interpreter of any kind present. And you can see 43% had no interpreter present with the physician at the time of hospital admission. 40% had no interpreter present in subsequent encounters with the physician following hospitalization. And 63% had no interpreter present with nurses during the time that they were in the hospital. And so as we think about barriers to use of interpreters, this study used qualitative interviews with residents to look at some of the issues that were driving that underuse of interpreters that we see there. And this resident talked about this phenomenon of getting by. So here the resident says, I know that when people are very pushed for time, they may or may not call an interpreter. They may just get by on the few words they know in different languages. And this quote, I think, is more worrisome. This quote says, I feel guilty because I feel like I'm not doing my job. And it also makes me feel very frustrated and upset at how our hospitals and clinics are run, that we allow this to happen. There's a lot of sentiment that, well, maybe patients with LEP shouldn't be getting healthcare. I think the reason that I feel badly is because I know that I'm not giving equal care to my patients. So here you can really hear this resident describing that direct connection between underuse of interpreters and inequities in healthcare. Okay, so now I'm going to shift gears a little bit and really focus on patients with serious illness. And so the kind of setting the stage for this is that data that I just went through, right? Which showed that patients with LEP experience poor clinical outcomes, including hospital readmissions, adverse events, barriers to health services, and underuse of interpreters, despite guidelines to the contrary. When we think about serious illness, you can imagine that how these cultural language barriers, literacy barriers are all amplified as we have really high stakes communication and decision making happening. And before I go there, I want to make sure to define the terms palliative care, hospice, and end-of-life care because people still sometimes tend to get these terms confused. So as we think about palliative care, we are talking about specialized medical care for patients with serious illness and their families that focuses on quality of life. And as you can see here, palliative care ideally is provided concurrently with life-prolonging therapies in the setting of serious illness. As you see disease progression, right, as we're moving from left to right in this figure, the proportion of palliative care increases, that proportion of focus on life-prolonging treatments may start to decrease. Now, the hospice benefit, as defined by Medicare, provides hospice care to patients with an estimated life expectancy of 6 months or less. In other words, palliative care is this broader umbrella. Hospice is the piece at the far end that's really focusing on the last 6 months of life. The term end-of-life care, which doesn't really have kind of a specific quantitative definition, is really focusing again on that period of care that is towards the right side. So key findings from this systematic review, this is from 2016, that focused on interpretation at the end of life, included that providers frequently relied on family, including minors, to interpret information about diagnosis and prognosis, that when professional medical interpreters were not used, patients and families had an inadequate understanding of diagnosis and prognosis. Patients had worse symptom management at the end of life, and family members experienced emotional conflict, particularly if it was a family member who was having to do the interpreting. They also experienced high rates of psychological distress. And in this kind of further exploration about barriers in the setting of end-of-life communication from the perspective of interpreters, and these were Spanish-speaking and Chinese-speaking medical interpreters in particular, interpreters highlighted a couple of additional challenges. And those include the challenges with translating palliative care jargon specifically. And now we're talking about things like do not resuscitate orders, palliative care, hospice, things like that, comfort care. And so interpreters talked about how important it was in those situations to have clinicians who really understood these terms and were able to effectively communicate in depth about these terms, that leaving it on the interpreter to be the one to really explain what a do not resuscitate order is really challenging and can lead to a lot of problems because there are no ways to kind of strictly interpret some of these terms. In addition, I think it's worth noting that interpreters here reported that they rarely received feedback and rarely had an opportunity to debrief with the team after an end-of-life discussion. So a real opportunity for improvement there, I think. And then interpreters reported a conflict between strict interpretation and cultural brokering. And a lot of this really speaks to how sensitive these conversations are. And so the additional challenges that are placed on interpreters when they're communicating about bad news, end of life care, things like that. And some of those barriers that I think we just talked about from the interpreter perspective may be driving some of the findings that were evidenced in this study. So this was actually an Australian study where they recorded conversations about prognosis between cancer patients and their physicians. And they looked at kind of three categories here. So they had Anglo-Australians, they had immigrants who had interpreters, immigrants who did not have interpreters and didn't need interpreters as the other group. And they found, as you can see highlighted here in these red boxes, that oncologists used more jargon with immigrants with interpreters specifically, and made strikingly fewer statements of hope to that group in particular compared to these other groups. When they looked at just the subset of discussions that included an interpreter, they found that 23% of physician prognostic statements were not interpreted at all. That among statements that were interpreted, only 27%, were not interpreted accurately. And that 59% of statements about prognosis that were made by patient or family members were not interpreted to the physician. And here's a quote to illustrate an example of a statement that was not interpreted accurately. And this quote is actually from a situation where it was a family member who was interpreting. So the physician here says, "We think there's a 40% chance that the treatment will prolong your life." And the interpreter says, remember again, family member interpreter, says, "The treatment will prolong your life." So you can see there how a critical piece of information was lost in translation. And in this quote, and this is actually with a professional medical interpreter, the physician says, "But you have a reasonably good chance to respond to the chemotherapy. And therefore, I should be able to control this cancer for months and months." The interpreter says, "But you have a great chance that if the chemotherapy works, the disease should be under control and your life, should be able to be prolonged and prolonged." So there you can see there is no mention of months, right? That important quantitative element that the physician was trying to convey. And in data from our own institution, Thornton and colleagues found that families, with limited English proficiency received less information and less support in family conferences with interpreters versus those who were English speaking. Interestingly, they didn't find any significant differences in the duration of the meeting, right? And I think one of the big barriers that we think about in terms of using our interpreters is this idea that it's going to be this really long conversation. But what that means is because the duration of the conferences were actually similar, clinicians made shortcuts in terms of cutting out some of the statements they would normally make, providing emotional support. And so this meant not providing or valuing family input, not making statements that would ease emotional burdens, and not showing active listening. And in this analysis of that same data set, now this is focusing on just the family conferences where there was an interpreter present, they also looked at how accurately medical interpreters were interpreting. So similar to the oncology data I presented earlier, this is now in the setting of ICU family meetings. Finding number one, that alterations occurred frequently. Now, some did have the potential to positively affect communication. And here's a quote that illustrates that. Here the doctor says, "I don't know what else to say to you. I mean, I told you yesterday that he's essentially brain dead. I don't know what you expected from that. I also said yesterday that there's no recovery from this. The interpreter translates that to, I told you that his brain was dead and it wasn't going to recover. So here you can see that the interpreter has really kind of softened the tone, softened the language as a way to maintain rapport with the family. Unfortunately, though, the majority of these alterations that occurred in interpretation actually had potential for negative consequence. And that meant negative consequence across information disclosure, thinking about treatment decisions, emotional support, rapport, as well as interpretation of family member questions. So here the doctor says, I don't know. This is a very rapidly progressing cancer. The interpreter translates that to, he doesn't know because it starts gradually. So here you can see really altering the meaning altogether. Another example, the physician says, have you spoken to your husband about these kinds of questions before he got sick? What his wishes might be in this sort of situation? The interpreter translates that to, did you talk to your husband before he got so sick about possible situations, what was awaiting him? So whereas the physician was trying to elicit whether the patient had previously expressed preferences related to end-of-life care, the interpreter has changed the meaning of that sentence to really kind of drop that key element of the question. And in this example of where an alteration occurred related to the family asking a question, the family member here says, but what we want to know is that after his lungs get better and when he wakes up, will his brain suffer and affect his ability to recognize people? The interpreter translates that to, okay, she wants to know about the lungs when he wakes up. So about his lungs, what about after? It will not affect him, right? So again, really missing a key element to the question that the family member had raised. So now let's turn from interpretation to looking at some of what we find when it comes to end-of-life decision making. This study used data from the Mayo Clinic. So this is representing the population that is representative of the demographics in the state of Minnesota. You can see that breakdown there on the left. They found that patients with limited English proficiency were more likely to receive mechanical ventilation. They were more likely to have restraints used. And they were less likely than those with English proficiency in the ICU to change their code status from full code to DNR. When they did make that change, it took 3.8 days longer on average. They were also less likely to receive comfort measures. And when they did transition to comfort care, it took on average 19.1 days longer to do so. They also were less likely to have advanced directives. And I would say that many of these findings are similar to the findings that we see when we look at racial and ethnic disparities in end-of-life care, with minorities being more likely to have intensive care at the end of life and less likely to do advanced care planning or have a do not resuscitate order. As we look at data from our own institution, this is preliminary data actually from a project that I'm working on where we looked at data for older adults who were attributed to UW medicine. So they had either inpatient or outpatient care through UW medicine and who died between 2010 to 2015. These are unadjusted analyses looking at those with limited English proficiency versus English proficiency. And you see across the board here that patients with limited English proficiency are more likely to have intensive care at the end of life, including dying in the hospital, dying in an intensive care unit, being hospitalized in the last 30 days, as well as the last 6 months of life, more likely to have ED visits during that time, and more likely to have ICU admissions, and then being less likely to have a healthcare directive or a post form in the EHR. And just to put some perspective on the demographics for this population, so remember here we're talking about older adults, those aged 65 and over. So this group was actually about 55% Asian, about 24% white, with Russian being the primary language spoken by the group, and about 7% Hispanic or Spanish speaking. And as we look again at kind of intensity of end-of-life care in this large study from Canada that looked at almost 1 million decedents, they looked at recent immigrants compared to immigrants who had come previously, compared to kind of native-born Canadians. They found that recent immigrants, of whom the majority had limited English proficiency, were much more likely to die in an intensive care unit. In the last 6 months of life, recent immigrants, again, were more likely to be hospitalized, be admitted to the ICU, have mechanical ventilation, have dialysis, have a PEG tube or a tracheostomy. And in this graphic here, you can see the relative risk of dying in the intensive care unit. Now, again, remember, this is a decedent population. So we're talking about the relative risk of dying in the ICU versus dying somewhere else. And you can see how that relative risk varies by the region of origin, with the dark blue being those with the highest relative risk. And in this map, you can actually see that it's South Asia that has the highest relative risk. So Canada having a very large South Asian population, but you can also see that across Africa, and then getting to Europe, Latin America, that you also see a much higher relative risk of dying in the ICU compared to other places, compared to the native Canadian population. Now, one of the issues as we think about how to really understand intensity of end-of-life care is this question about how much does that reflect patient preferences, right? So we have data that shows that patients who die in the hospital in the context of serious illness, a lot of this data coming from advanced cancer, that those people have a poorer quality of life at the end of life than those who die at home. We also know from community survey data that a large proportion of people would prefer to spend their end of life at home and not in the hospital. So that's kind of one piece of data that we sometimes look at to indicate that maybe people's overall preferences are not to have this kind of intense end-of-life care in the setting of a serious progressive illness. At the same time, as we think about some of the data that looks at racial and ethnic differences, as we think about the role of cultural beliefs, we again see preference for more aggressive care at the end of life. The question, though, is, does that data suggest that that's really what people would want? Or is it reflective of disparities in communication that result in those preferences, and yet they're not actually aligned with people's values and goals? And that, I think, is the real question, is trying to unpack, are we failing people in terms of how we're having these conversations? And I showed you a bunch of data about interpreters. And when information about diagnosis and prognosis is not kind of correctly being interpreted, is that actually driving the kind of care that people are receiving, and it's actually not in line with their values and goals? And so this next study here tried to get at that a little bit in looking at how certain people were about their treatment preferences. And so in this study of English and Spanish speaking participants, although they did have diversity within the English speaking group among different racial ethnic minorities, looked at how certain people were about their advanced care planning treatment preferences. So this is getting at kind of one aspect to that question about, are people making truly informed treatment preferences? In this data, you can see towards the bottom here, that box that's highlighted in red, that for those who either spoke English as a second language or were Spanish speaking, they had far more uncertainty about their treatment preferences than those who were English speaking. So again, I think this raises the question of, How much can we make from that data that shows that LEP patients are receiving more intense care? How much can we make about that data in light of the possibility that actually they're not sure about those preferences, those decisions, and that rather they don't even understand the fundamental aspects of what's going into those decisions? And so in this study, looking at Asian and Hispanic adults and kind of openness and knowledge about hospice, you can see here that there are differences between groups. So in the same way that that map I showed you from the Canadian study showed that the relative risk of dying in the ICU varied between region of origin, in the same way, this data highlights how different groups may have not only different preferences, but different beliefs. And I think that's, a key point that we highlight when we talk about kind of racial ethnic disparities in care, and is really critical when we think about the limited English proficiency populations. This is a very heterogeneous group, and we need to be very careful about generalizing findings from one subgroup to another subgroup. So here you can see data about Chinese-speaking, Korean-speaking, and Spanish-speaking individuals. Big differences in terms of whether they had ever heard of hospice, with almost 50% of Chinese and Korean-speaking individuals having heard about hospice, only 16% of Spanish-speaking individuals. A common theme for the three groups was that they had very few people knew anybody who had used hospice or had anyone in their family who used hospice. And again, some commonality with a large number saying that they would tell their family about hospice services and that they would actually like to receive more information about hospice, although you see some small differences between the groups here. So the takeaway from this data is there does seem to be receptiveness to talking about things like hospice and thinking about hospice care, in contrast with what we're seeing in terms of the reality that people are getting very intensive care at the end of life. All right, so in thinking about kind of all this data I've gone through, I want to bring it back to this conceptual framework that I had shown earlier as we think about how do we start to think about addressing these inequities that I've just finished talking about for patients with limited English proficiency. And in this framework, I've now kind of added community factors there at the bottom, which is was not in the kind of original framework, but I think is critical as we think about approaches to addressing inequities for this population. I've highlighted in red language services and use of interpreters. So I think, hopefully it's clear by now as we went through some of the data about underuse of interpreters, as well as about communication errors occurring even with the use of interpreters, that a key place of intervention as we think about how to improve the quality of care for patients with limited English proficiency and serious illness has to be around access to language services and use of interpreters. I would say, going back to that systematic review that showed that providers frequently use family members, including minors, to talk about diagnosis and prognosis, that, that really should be unacceptable. To have minors trying to convey information about prognosis is really, really unacceptable. And so we have to think about how we can ensure that every person who needs an interpreter has access to a professional medical interpreter during all of their healthcare visits. I think we definitely need to think about how we can do a better job of that in the hospital when we think about interactions with all clinicians, but particularly with nurses. How can we improve language access for patients when they're having those interactions? So that, I think, is kind of a starting point, is thinking about how to improve language services and use of interpreters, recognizing that for patients with serious illness, the communication is so much more complex that it is essential that we make sure that people are actually understanding the information that they're being given to ensure that the care that they receive is truly goal concordant, right? That it reflects their values and goals. But beyond thinking about interpreters and language services, I would argue that really the way forward is to think about multi-level approaches. We need to think about what kind of interventions we can do at the patient side, thinking about, low literacy, having linguistically appropriate materials, culturally appropriate materials, then thinking about the clinical encounter. Again, I think that's a lot about interpretation and communication. How do we intervene upon some of the provider factors that are driving some of these inequities, right? We talked about things like residents and other clinicians underusing interpreters despite knowing that it's important to do. So we need to think about how we can address some of the barriers to make it easier for that care to happen. Thinking about our healthcare system, and then finally, really thinking about the way in which community-based organizations, these are places where there is inherent levels of trust, right, with the population that that community-based organization is serving. How do we really partner with these community-based organizations to improve access to care, to improve access to information that is culturally and linguistically appropriate, so that we can ensure that every patient is actually able to get equitable care? So that's what I would say as we think about next steps, is to think about how can we really develop multi-level interventions. These are the kinds of interventions that I think are going to have the most success at ultimately addressing inequities in care for this vulnerable population. And so with that, I'm going to end on my questions slide here. This is a picture of a mural that's actually was installed at the Asian Counseling and Referral Services in Seattle by a local artist. I think one thing that's pretty cool about this picture are the rainbows that are kind of going through, which kind of symbolize a connection between people, thinking about how through empathy and respect, we can all work together to make sure that everybody is treated with respect and dignity. And so that's, on that note, I will end and take any questions.
Thank you so much for a really comprehensive presentation of some really important data that really impacts all of us who care for patients. There's a number of questions for you, one of which is, in the light of COVID, we're using telehealth more and more, and how do you see that factoring in for caring for folks with these kind of barriers?
That's such an excellent question. I mean, I think that that is both an opportunity, but also something that we need to think really carefully about. And I'm going to talk about that really in the context of palliative care. It's an opportunity because I would say that on our inpatient service, and it enabled us to have family meetings with family members all over the place, right? It wasn't just the family member who lived locally who couldn't come in because of the visitor restrictions. It was somebody who's on the other side of the country. It was somebody who can't come in because they're working, but, or somebody that's actually in another country. So I think the opportunity is that we can really use this technology to be able to have these conversations with people who need to be a part of the conversation, but kind of didn't have access to that conversation before. I think what's challenging for the palliative care piece of this is that these can be really emotionally intense conversations. And so, the challenges with not being able to have that same kind of like physical touch or physical interaction with someone who's crying, is really hard. And same thing, I think we've had situations where interpreters were kind of shell-shocked, right, with some of the information that they're having to translate. And so I would say that when using telehealth interpreters, it is critical to have that pre-meeting. And I would really encourage people to think about having a debrief because, the interpreters are kind of like thrown into the middle of this really intense conversation and then have like no way to kind of process what just happened or to have context for what just happened. So that would be something that I would kind of encourage people to think about, as I think this practice is going to be kind of more and more common.
Yeah, absolutely. Another question from the audience is, what do you suggest when a family member refuses an interpreter, preferring that they be the sole interpreter, which seems to be sometimes an issue that providers find?
Yeah, I think that, that question comes up a lot. And I'm going to acknowledge Jose, who worked for a long, long time, has a CCM over at Harborview, who talked to me about this. And so I'm going to kind of channel him as I answer this question. He would really phrase it to families as a way to offload the emotional burden that family members are kind of experiencing as they're having to do both things, right? So a common thing that he would say, sorry, my headphones are just wanting to constantly like jump out of my ears. So a common thing that he would say to families is like, we have this service here to help you just be a family member, as opposed to trying to both paying attention to like what we're saying and interpreting, and not being able to just be in your role as a family member. So I think approaching it from the sense of like, this is a way to help you, not a way that we're questioning your ability or competency to act as an interpreter, but rather that we're trying to help you because we recognize that trying to both be an interpreter and a family member is too much.
I think that's a phenomenal way to frame that and make that very family and patient centered. I'm definitely going to be using that in my practice moving forward. So much appreciated. There are a few questions coming in from multiple people from the audience asking about the difference between a medical interpreter and a cultural mediator. And then a second part of that is another question of, is there thoughts to expanding the role of some of our interpreters to include kind of cultural brokering as well?
Yeah, so those are all really good questions. It also gives me an opportunity to just acknowledge the phenomenal work that the Harborview Community House Calls program does. In addition to the phenomenal work that the International Medicine Clinic does, I mean, we're really privileged to be at an institution that is doing incredible work for those with limited English proficiency. And having gotten to kind of know more about the CCM program, I'm just amazed at just the kind of wonderful work that they're doing. So I just wanted to say that. As I think about the difference between an interpreter and a cultural mediator, it's a good question because I think, I would say that the CCM program brings kind of an additional skill set, right? So it's not just interpretation, it's about advocacy, it's about mediation, it's about kind of case management and navigation. And so it's not just about making sure that content or information is communicated well in the clinical encounter, but it's about kind of addressing all of the other barriers that impair the ability of people to access the healthcare system, to get to the appointment on time, to understand why it's important to be at that appointment, understand, and have someone who they can trust who can help speak up. I mean, a lot of times people feel that with this, kind of hierarchy, that being able to kind of advocate for themselves to the physician is just kind of not part of the kind of, cultural context. And so an interpreter is not going to necessarily do that, whereas a cultural mediator can really come in and I think kind of help that advocacy part. And if we had more resources to kind of support this work, I think that's the kind of work that can address these multi-level barriers that I talked about to health inequities, more so than just, interpreters in and of themselves.
Yeah, I think that's a really great point, that it goes far beyond just the language itself. There's a question from the group of, can you comment on standard for interpreter proficiency? It seems some folks are commenting that they've had a wide variety in skills and in kind of accuracy in translation, if you don't mind commenting on that.
Yeah, I mean, that's a challenge, right? Like I reviewed data about kind of underuse of interpreters, but it's frustrating then when you're doing the right thing and you're using an interpreter, and yet you feel like that level of interpretation isn't that great. I mean, I would say that my understanding, and there are others out there who have greater expertise in this than I do, my understanding is that our different campuses have different I don't know if standards is the right term, but have kind of a different way of, I'm going to use the word standards, have different standards in terms of what level of kind of certification is required by interpreters. I know that Harborview, for example, has, I think, a particularly high bar for ensuring that the medical interpreters have gone through all of the certification and licensing to both to kind of demonstrate their competency in interpreting medical information in the language that they're interpreting, as well as to have kind of the additional training in ethics and kind of HIPAA and things like that, which I think is also important. So I do think it's critical for us as a system, UW Medicine, to think about how can we ensure that the interpreters who are working for us have that level of skill. And I would say that is one of my concerns around the telehealth piece is, I don't know what the level of competency is for that Zoom interpreter. And so I think we need to really make sure that we have some way of assessing or making sure that the people that we're using now, through those venues do have the training they need to properly interpret. I will say one really quick thing. I think if you're in a clinical situation where you feel like you're really unsure about kind of what the interpreter is communicating, that's a great time to do some checking in with the patient. And so being able to say, I would say in those situations, definitely saying to the patient, can you tell me back through the interpreter kind of like what you took away from what I said? That can be one way to kind of make sure that at least the bulk of the information that you're trying to get through is getting through.
Yeah, I think that's important for all of our patients, but particularly when using an interpreter. In kind of a similar troubleshooting vein, do you know of anyone who's looking at the real-time translation apps on cell phones? And if that impacts, I can imagine where folks might want to substitute an app or technology for an actual in-person or telehealth interpreter.
I don't know. I haven't seen data looking at that. I know that people are very interested in looking at that. I definitely worry that when it comes to palliative care and having things like goals of care discussions, that's a time where we really need to make sure that we have confidence in the level of interpretation that's going on. Not to mention that there you also, I think having that personal connection with people, like even being able to have, in-person or video over phone interpreters makes a difference in that setting.
Yeah, absolutely. Well, again, thank you so much for sharing your really impressive work and really important work in a field that impacts all of us who care for patients. And thank you so much. I learned a lot from you and appreciate all that you do. So I'm thankful you were able to carve out some time to spend with us this afternoon. And thank you everyone for attending another Grand Rounds. Hopefully we'll see you all back here next week for our lecture. It's a Falco lecture in nephrology, and so it will be some basic science based on renal therapeutics for kidney injuries. So hopefully we'll see you all there, and everyone have a great Friday and a safe weekend.
Thank you, and thank you again for having me. Happy Friday, everyone.
Take care.